All right, great. Well, thanks for your attention for a broad sweeping topic this early in the morning. I'm not sure how many of you woke up and called your family excited about hearing a talk about histocytic disorders first thing. But I would encourage you to embrace this topic because the only reason I passed my boards was because 20% of the questions were on HLH. First, the weird stuff is easy to ask questions about, and so this talk is basically just all the weird stuff we see. So for disclosures, there's my potential conflicts. And I think I also want to make a specific disclosure that I've organized this talk very differently than I organize most talks. This is specifically to teach to the test. If you learn something about clinical applications or scientific interests that's purely unintentional, and do not use this to supplement a body of knowledge of actual research. And if I say, if something's in red, pay attention to it because it's brought up in the board review manual multiple times. So unlike Pat, I didn't highlight the ABP questions, but every slide is based on an ABP question. And for me, I think one way to sort of handle this huge array of bizarre and different diseases is to just kind of think about where does it fall in hematopoiesis, what's wrong with the cell, and then you can kind of reason your way through the answers rather than having to memorize everything. And so here you only have to pay attention to this side. You can completely ignore this side for this morning. So half of hematopoiesis is taken care of. So to start with, talking about myelodysplastic syndromes and myeloproliferative disorders, I think they get kind of clumped together, and it's not really clear what people are talking about when they say myeloproliferative or myelodysplastic. A lot of this is based on classification committees and the WHO. But basically what we're talking about is something's not quite right with the stem cell going through the myeloid lineage. We're going to focus on what are the different things that can happen when that gets messed up. All right, myelodysplastic syndromes. So again, I think MDS really represents a huge spectrum of disorders that sort of manifest that the bottom line is your myeloid lineage is broken and not working normally. And putting a epidemiology around it, I think, is a little bit silly because there's so many different things we're talking about. But I think what is important is this WHO classification that kind of provides a framework for us to think about these disorders. So refractory cytopenia of childhood is when you're just starting to have some problems with myelopoiesis, but you're not really starting to see evidence of the struggle of increased blasts yet. And then sort of as you work your way through reactive anemia with excess blasts and then refractory anemia in transformation, you're starting to stress your sort of myeloid engine so much that you're starting to get some early signs of potential transformation, and then you get frank AML, as Pat just talked about. And then we have these specific classifications we'll talk about, and then Down syndrome. I strongly encourage you to know everything there is to know about Down syndrome because that's easy to test and it seems to show up almost as much as HLH. All right, so I think we all see this in clinic that a lot of things can cause problems with myelopoiesis. So infections, vitamin deficiencies, metabolic disorders. I mean, you just think about your patient who shows up with an unusual cell count, maybe too many monocytes, maybe too few monocytes, and it starts to put you down a certain pathway. And I apologize for the Pearson's typo. It's not Pearson's, it's Pearson syndrome. And then there's hematologic disorders. So when you start seeing your marrow not act normal or you start seeing evidence in the peripheral blood, it causes us to start looking at inherited bone marrow failure syndromes, aplastic anemia, et cetera. So I'll say again, another issue for this talk is I have way too many slides and way too many words on them, and the reason for that is so you can go back and study it. We don't necessarily have to focus on every word on every slide during the talk today. But again, we'll highlight, when you see red, pay attention. So monosomy 7, think MDS. So for cytogenetics, when you have monosomy 7, it's really a sign that you might be in trouble with myelodysplastic syndrome that's going to be clinically problematic. And then when you start getting some questions about trisomy 8 and trisomy 21, that could be a trick question because you want to make sure you don't have germline mosaicism. So I think that's something, if I were writing a question, you might think about tricking somebody with. And then if you start to do cytogenetics and you see there's a lot of chromosomal problems, that suggests there's something wrong going on here, more than just simply a stressed marrow. And then there's the secondary MDS that Pat talked about. So RAB in children, so this is one of those questions, how is it alike or different than adults? And I think one difference is that in kids, you can have your count sort of stable for months with nothing really going on. And as Pat mentioned, you don't really need to use induction if you're going to transplant someone who's got RAB in transformation. So another question that the board asks you to know is what's the histology of refractory cytopenias of childhood? This is the most common subtype of MDS. And I think unlike adults, you're going to see less cellularity in the bone marrow, so you're not going to have so much packed marrow all the time, although it certainly can happen. And if you don't have a cytogenetic clue, you really have to do at least 2 bone marrow evaluations 2 weeks apart to fulfill this refractory component, right? Otherwise, you just have one marrow with sort of some kind of insult that could be transient or it could be substantial. And then aplastic anemia is going to be covered in another talk, but really the difference between the diseases we're talking about and aplastic anemia is sort of hitting the stem cell versus hitting a more committed myeloid progenitor. So we're going to have sort of more problems with myelopoiesis in general compared to aplastic anemia, but there's huge overlap, obviously. And these are some pictures that Ken McLean's used in his talk before, and you can see these just look like kind of angry myeloid cells trying their best to develop, but they're not quite doing it right. There's signs that things aren't quite right, and you can kind of look at that later for the different forms of histologic abnormalities. All right, so when do you have to worry about inherited bone marrow failure syndrome? Well, I think always, right? So I think whenever you have RCC, you need to stop and think: is this a Fanconi? Is this a dyskeratosis? Is this an AT that we're dismissing? And I think more and more now we're realizing that there's inherited risk. So germline mutations, all the things that we see in our AML readouts, the somatic mutations, you can also have as inherited risk factors. And I think GATA2 is something that's going to be a big deal on boards. I'm not sure if it's going to quite catch up to your boards, but just in case, you should be aware of it. So inherited mutations in GATA2 are leading to monomax syndrome. So basically, you have specific deficiencies in the myeloid lineages. And these patients can develop over either in childhood or adulthood, all kinds of bizarre infections. But just remember, GATA2 and monomax syndrome, if you're missing macrophage, if you're missing your monocytes, and you have lung problems, lymphedema, think about GATA2. All right, so treatment. Again, so how do you treat this huge array of conditions that have sort of a common phenotype? I think you just have to treat it like we do any other patient, where you observe if appropriate. You look for inherited DNA repair defects. If you find them, that may inform the decision to go to transplant or not. Immune suppression might be useful if you're having some overlap with aplastic anemia. You support with transfusions. If you get AML, you treat AML, and if things look like they're not getting better, go to transplant. All right, so now to some more specific myeloproliferative disorders. I think this slide highlights probably some themes that you'll see over and over again in boards. So just again, for the very high level view, for Down syndrome, just remember Down syndrome AML, compare it and contrast it with M7 AML. How are they alike? How are they different? We're going to talk about that a little bit in a second. JMML is another disease that we probably see once every year to every 5 years, depending how big your practice is. But you'll see a whole lot of it on your boards. So we'll spend some time talking about the MAP kinase pathway mutations, diagnostic criteria, and therapy. And then CML, Pat just talked about, and so just to prove Pat's right, look, priapism, it's there. I've never seen it, and it only gets half the patients with CML, so I don't know why the board's focuses on it. So, all right, so what we're talking about now are these diseases where, oops, I'm going to stop using that. Where basically you have a problem with control of the growth of your common myeloid progenitor and Down. And you may sort of bias towards one spectrum of differentiation or another, but basically think about it as uncontrolled growth or uncontrolled activation of a common myeloid progenitor. All right, so we're going to talk about Down syndrome for a second. I've always learned TMD. I have a hard time saying TAM, so if I flip between them, forgive me. But I think transient abnormal myeloproliferation is what the boards likes to see. And so when we have kids with Down syndrome, or when we have kids who have an abnormal smear at birth, sometimes it makes us take a closer look. Does this kid have Down syndrome? This is such a fascinating biological phenomenon. I think that we can't help but to ask questions about it. All right, so the incidence, 10%, the books say 10% of children with Down syndrome are going to get this problem, although if you really look, it's, it could be up to 30. But anyway, it's a significant problem. Not everybody, but certainly a significant portion of kids with Down syndrome get this phenomenon. And so when you have this abnormal myeloproliferation, it sets these children up for a 10 to 20-fold increase in AML, and it's going to be the M7 phenotype of AML typically when they get that. So remember, but that's one that you have to remember. All right, clinical characteristics. So this can be babies, and it makes sense if you think this is, and we'll talk in a second about the pathogenesis, but your fetal hematopoiesis going from your liver to your bone marrow, that's when you have this wave of abnormal cells, and then in some cases it'll go away if that clone doesn't manifest in the bone marrow. So remember, these are going to be babies in the NICU. 85% of the time it's going to go away by itself, usually by 3 months, but 20 to 30% of the time it's going to at some point pop up again as frank AML. All right, pop quiz. This is one that is always a favorite in the board. So, which is the most common leukemia in children with Down syndrome? Is Pat still here? Did he leave? Okay. Anyway, so the answer, ALL. So even though we're talking about AML and all this predisposition, even though you have a much, much higher relative risk of AML, ALL is still more common in kids with Down syndrome. So don't miss that one. All right, so memorize this slide. Down syndrome TAM, so the origin of the bad cell is from the fetal liver. You have germline trisomy 21, and you have a somatic GATA1 exon 2 mutation. The exon 2 will show up on your exam, so remember GATA1 exon 2, as opposed to GATA2 germline, which gives you monomac. That can get confusing. All right, so how is TAM different than Down syndrome AML? So the blast can be indistinguishable, okay? The GATA1 exon 2 mutation will arise in the fetal liver in TAM, but it'll persist in Down syndrome AML. Usually AML, you'll have additional mutations besides the GATA1, and it'll be, the difference is that it's leukemia. It's not myeloproliferative. It's not just myeloproliferative. So just kind of think about it. It makes sense that you basically have this precursor in the TAM that then sort of takes a few additional hits to become AML. All right, the bone marrow and TAM can look like a lot of different things. Fibrosis can be common, and that sort of makes sense with the M7-ish phenotype. You can have, blasts and it can look more or less the same in the marrow as it does in the peripheral blood. In general, the phenotype is more mature than it is in AML, but it's not universal. So I think that'd be sort of a hard thing to test on. But just be aware that these are cells that they're trying to mature, but they don't quite mature. And so when something transforms into AML, it's going to really be a much less differentiated blast. The clinical course, so it's not trivial, even though TAM can spontaneously resolve. You can have mortality in 20% of kids, and that's not just including the 20 to 30% that develop AML. And risk factors are going to be preterm delivery, congestive heart and liver failure, hyperviscosity, DIC, effusion. So basically, if you have such a big cellular burden from your myeloproliferation, that's really what can cause problems. The board's asked you to look at risk categories. There's not a lot of sort of codified risk categories, although the COG 8297 study did a nice job of retrospectively looking at what kind of phenotype leads to what sort of problems. And basically, if you have hepatomegaly, that's not good. And the more adverse features from that previous slide you have, it's not good. I wouldn't really bother memorizing the specifics of it, just to know that there's this range of low risk and high risk. Low risk being almost universal survival and high risk being 50-50. All right, so how to treat. So the first thing you do is diagnose, and then once you diagnose, you can just sort of figure out, what's the situation, what does the situation require? Either just exchange transfusion, leukapheresis, or probably what may show up on your test is just low dose ARC, and just kind of keep giving ARC pulses to treat the tumor burden. All right, next pop quiz. So which has the best event-free survival? Down syndrome with AML or kid without Down syndrome who's got AML? All right. So this is one where the Down kids get a break. It's one of the few things where they get a break. Usually, not always, of course, but Down syndrome with AML, that's associated with TMD is typically better. There's a caveat to that. If it's not M7 and if it's not GATA1 exon 2, then all bets are off and they're just like everybody else. All right, so which has the best event-free survival here, Down syndrome ALL or normal karyotype ALL? So we all know that Down syndrome ALL is bad news, but that's not my talk, so we'll keep moving. All right, so features of Down syndrome AML. So it's usually an M7 phenotype, and their outcomes are not horrible for AML, and so they do have a modified therapy, as Pat mentioned. However, if they're older than 4, if they don't have GATA1, it's probably regular AML, so they don't get a break on that one, and you have to treat them like anybody else who has AML. And again, I think that this bottom figure sort of gives you the reason why there's that trick question. So Down syndrome ALL to Down syndrome AML is 1 to 7, where ALL to AML and non-Down syndrome is about 6 to 1. And so even though you have a much, much higher relative risk of AML, ALL is still going to be more common in Down syndrome. All right, now we're going to move on rapidly to what else can go wrong with your common myeloid progenitors. So JMML is one thing, and I was sort of horrified to see Mignon on the list. I hope if she's here, please feel free to correct any inaccuracies I have in my talk. So JMML is just a beautiful biologic problem, which is why it's easy to test. And so even though many of us may never actually even see this in our clinics, it's something that you really should spend some time understanding. So it's 1% of all leukemias. It's about one or so per million. It usually shows up in young kids, and it'll show up with someone who's got too many white blood cells. So again, you just sort of have this burden of sort of aggressive myeloid production. So the key features, though, for your test: monocytosis, increased fetal hemoglobin, splenomegaly are the key features of JMML. And the outcomes aren't great, even though it's sort of this smoldering, indolent, kind of histologically bland disease. It's not good. Right? And so I tried to get a peripheral blood smear. We can't use copyrighted material or anything from the web or Wikipedia. I was unable to get one, so anyway, your homework is go look up a peripheral blood and bone marrow, because that would be something I think could show up on the test, that the bone marrow and the blood smear more or less look similar, where you have this sort of increased immature myeloid cells. All right, and I think the story of JMML that's sort of evolving is interesting too, that not only do you have somatic mutations in RAS pathway genes, there's also these syndromes that are associated with increased risk of JMML. I think Noonan syndrome is the one that you'll probably see in your test. So a baby who has heart defects and kind of a weird face ends up having sort of increased monocytes. What do you worry about? That's going to be JMML. So they ask in the sort of ABP thing about differentiating between different kinds of JMML, and there's so few cases. I'm not sure the literature is really super strong about differentiating between we don't have enough numbers, I think, to make huge assumptions, but I'll go through some things here that I think we can more or less generalize. So you have somatic or germline activating mutations in RAS pathway. So know these things. So that if you have BRAF, that's not the right answer. If you have P53, that's not the right answer. It's got to be sort of a RAS pathway gene that's sort of up high on the RAS pathway. And then, so again, genotype, phenotype, correlations for the germline mutations are a little bit controversial. I'd stick with Noonan syndrome as the one to kind of commit to memory. So these, compared to somatic mutations, they're younger. They have a little bit better survival because there is spontaneous resolution, basically in most of the germline phenotypes. The cells can be polyclonal, again, because it's germline, it's not somatic, and they typically have normal cytogenetics. Sybil is worth pointing out because of a risk of vasculitis, and they actually have, I think, more of a chance of spontaneous resolution than others. And so there's, if you read the most recent, like How It Treats by Locatelli or some of Mignon's work, there's a suggestion that you kind of watch the Sybil mutations a little longer than others. All right, diagnostic criteria. So I noticed as I was reviewing this talk this morning that I left splenomegaly out of the big four, so you can pencil that into your slide. But clinically, you need to it can't be CML. You have to have lots of monocytes. You have to have enough blasts to count as leukemia, and you have to have splenomegaly. And the rest of it kind of makes sense. You have to have a mutation. If you don't have a mutation, then you have to have pretty strong biological evidence that RAS pathway is hyperactivated. All right, so risk factors. Again, I think spontaneous mutations have worse outcomes in general than germline mutations because of the possibility of spontaneous remission. If you get it younger, it tends to be better. And therapy. So you can just watch if it's germline and the patient is stable. Otherwise, you're going to commit to transplant, but while you're going to transplant, you can sort of give escalating doses of myelotoxic therapy depending on what the patient's needs are. And then, for those of those transplanters in the group, these patients are really difficult to transplant. They don't like to hold on to their graft, and so their outcomes are really not great. I think that RAS and PI3 kinase, AKT, mTOR inhibitors are being tested, but that shouldn't be on your test unless there's a theoretical question about, what kind of inhibitor would you think about using. All right, I don't have to talk about CML, but just know what it's different because it's got the Philadelphia chromosome. So you've got that tyrosine kinase signal instead of a more downstream signal coming through, and then just the things that Pat mentioned. All right, take a breath. We're going to shift gears now to histiocytic disorders, which I know is everybody's favorite. All right. So one of the challenges with histiocytic disorders is the current textbooks are all wrong about what they are and where they come from, but that's what your test is going to be based on. So let's go with that, okay? So histiocyte really just means tissue cell, and so there's been this sort of classification effort to try to figure out how all these different disorders fit, and it's really based on, well, what does the terminal phenotype of these cells look like, and how does that compare to normal tissue cells? And so that's how we sort of currently organize our thinking about histiocytic diseases. So really anything that's abnormal with a histiocyte or tissue cell counts as a histiocytic disorder, and that's why we're sort of mixing immune problems with neoplastic disorders. All right, so again, the classification is based on what it looks like. So dendritic cell proliferation, so LCH looks kind of like an epidermal Langerhans cell, so it gets classified there. For macrophage proliferation, JXG. Erdheim-Chester is basically JXG in adults. You shouldn't get that on your test because it's really only in adults. Rosai-Dorfman disease is, I think, sort of common terminal phenotype we really don't understand very well, but it gets grouped as its own thing. And then HLH. So HLH is sort of biologically totally different than any of the rest of these things, but we'll still leave it together for historical purposes. And then you get to malignancies, which I'm not going to talk about because Pat already did. All right, so right now the current textbook is going to say, LCH is really sort of somewhere between this macrophage and dendritic cell phenotype. It looks like it, maybe sort of arises from this sort of terminally differentiated histiocytes. In 2019, this will be part of the MPN talk. These are all sort of disorders of myelopoiesis that end up with this. The tip of the iceberg is really what looks like dendritic cell. But anyway, I promised you no research, so let's move on. All right, so pop quiz. So a PCP calls you with a 2-month-old who presents with a rash. They went ahead and got it. It wouldn't go away, so they got a skin biopsy. It's CD207 positive, so what do you do? Do you say, don't worry about it, that's going to go away by itself, or do you say, we should probably see this kid? All right, so this is my one lobbying point. So go ahead and see the kid, because 50% of the time they're going to have LCH in other parts of their body. So what does LCH look like? So on the test, CD207 or Langerin is going to probably be what you see, or CD1A positive cells. You also see these. Let's see, I'm trying to do this without flipping the slides. These Burbeck granules remember from our pathology textbooks. That may be asked. We almost never really use this clinically anymore, but it's a defining feature of LCH. And then unlike JXG, FASN and factor 13, that should be factor 13. Oops, that's not good. Add another 1 on there, or negative. And what we know now is that, and I think Mark Fleming's here. He's one of the people who really helped define the BRAF as one of the first somatic mutation identified in LCH, along with Barrett Rollins' group at Boston Children's. And so basically, again, to revisit this pathway that keeps showing up, so you've got RAS, RAF, MEK, ERK. You get a signal from that side of the cell that says, grow or move or do something. And then what happens in LCH is that BRAF, so there's A, B, and C RAF, so BRAF gets mutated and constitutively activates downstream here, leading the cell to grow and to become LCH. BRAF may be on your test. MAP2K1 encodes MEK. That's another recurrent mutation, so I would just be aware of it. It's not intuitive what that gene means, but it's another recurrent mutation in LCH. Okay, so LCH arises in about 5 to 8 per million children, slightly more common in boys than girls for uncertain reasons. Usually it shows up in younger kids, but we certainly see it in, we have a 85-year-old that we saw in our clinic last week with new LCH. For epidemiology, it's a little tricky because most of the epidemiology, I think, is not really completely proven. It's clear based on SEER data, so Carlos Rodriguez-Galindo and the Boston group did mine the SEER data, and I think they found what we all see, which is you almost never see LCH in Africans or African Americans. It seems to be more common in Hispanics and whites. There are some reports of increased clustering in families and increased incidence in thyroid and autoimmune, but I'm not sure if that's going to be kind of like Kawasaki's and carpet cleaning risk, if it's really true, or if it's just sort of ascertainment bias by early studies. But if it shows up on the test, go ahead, go with it. Okay. All right, so disease categories. So it's based on the organ that's involved, and risk corresponds to risk of death. So high risk is liver, bone marrow, and spleen. If kids have liver, bone marrow, or spleen involvement, they have higher risk of dying from LCH. Lung used to be in there, but that's been disproven as an independent risk factor. And then you can have multi-system low risk, and you can have single-system low risk, meaning you have lesions anywhere else. And then CNS risk I'm going to talk about in a second, and that risk talks about the risk of developing neurodegeneration, which is a late consequence of LCH that we don't really understand very well. And rather than memorizing each bone, really it's just sort of lesions in your front of the face and the base of the skull. If you have front of the face, base of the skull, that's a CNS risk lesion, and pituitary. So we'll talk about pituitary as well, because LCH loves the pituitary. And this just looks like some of the patients that I'm sure you see in your clinic, where you just either have one lesion that seems to pop up and you can do curettage and it goes away, or you can have really dramatic lymph node involvement or in bone, but in this case there's no risk organs, and even though it looks severe and it can be clinically problematic, this isn't considered high risk. But when you have the spleen and bone marrow involved, you can see a bone lesion here, that makes the patient high risk. The presenting symptoms are highly variable, so these kids can look like just about anything, which is why it's a great morning report disease. It's a great board's disease because it has a lot of different manifestations. So if your bone marrow is involved, usually it can be seen in cytopenias or hemophagocytosis sometimes. When we looked at a series, 50% of bone marrows that were read as normal, we found stem cells that carried the BRAF mutation. So I think we're still not really sure how to manage bone marrow, but just be aware that if bone marrow is involved, you can have cytopenias. Spleen can be involved, which usually shows up as splenomegaly. It can also cause problems with thrombocytopenia. And then the liver can be a severe problem with not just hepatomegaly, but biliary obstruction, jaundice, ascites, and even there's a late finding of sclerosing cholangitis that can require liver transplant. Skin can look like anything, so I think it's why we get so many kids who are sort of treated empirically before they see us, or take a long time to make the diagnosis. If you have the draining ear that never goes away, that's a classic setup for an LCH question. And then bones can show up as painful swelling or mastoiditis. Floating teeth, I'll show you a picture of, is another classic LCH test question. And then lymph nodes can be involved, showing lymphadenopathy. Lungs are another characteristic feature that it can be associated with smoking, isolated lung disease in adults, but it can also be part of multifocal disease in kids, where you just sort of have this honeycomb pattern, or you can show up with a spontaneous pneumothorax. I think something that probably goes under-recognized is gastrointestinal involvement. So you can have sort of patchy involvement of the intestines that shows up with diarrhea, edema, or if you have sort of low albumin but your liver's not involved, I would consider doing a scope. And then endocrine problems are huge. So 50% of the kids who have diabetes insipidus also have anterior pituitary problems, and this can be a big problem with sort of late sequelae. All right, so here's some pictures. So here's classic floating teeth. Sometimes you'll get parents very proud that their kids have all their teeth and they're only 3 months old, and that's not something that should happen. And you can see here, this is just sort of a kid with a minor scalp rash that you wouldn't really think that much about, that, maybe seborrheic dermatitis or something, but that turned out to be LCH. Or, more dramatic NICU presentation that could make you suspicious for CMV or some other congenital infection. And then here's something that, one that looked like maybe scalded skin or super infection. So you can't tell from a picture if it's LCH. You have to do a biopsy. All right, and then images for, how can you affect LCH above the neck? The one we most often see is the, 1 or 2 or a few lumps on the head, and they can be pretty significant, even though it can look dramatic, but even this, would just require curettage for cure, and you can kind of see how that, bores through the entire skull plate. All right, so this is one that I think Ken McLean wasn't able to give this lecture, but he told me to make sure I told Ken Cohen that this is the most important lesion in the pituitary. So if you have isolated diabetes insipidus, it's either our disease or Ken's disease. And so, sometimes you can figure it out by doing germ cell markers, but we don't have a great way of identifying, differentiating LCH in the absence of being unable to prove that it's a germinoma. And then this is the sort of neurodegeneration finding of T2 hyperintensity on MRI that you'll see that is sort of one of the really frustrating and challenging parts of LCH. We don't know how to really treat neurodegeneration or what it is. Right, and so here's one, a scenario that I guess this won't be a board question, but I think it's just important sort of to convey that, if you don't do anything, LCH fixes itself. So that's sort of a unique feature of LCH. So here, this kid just got chemotherapy and remodeled his skull. This kid got clear margins and now has a skull plate. Okay, and then vertebra plana is another classic scenario. Someone shows up with back pain, has vertebra plana, do a PET scan to look for other lesions. And here's an example of, you have someone who shows up with diabetes insipidus and has an abnormal chest x-ray, and then this is a surprise that you find. That's a classic picture for LCH. And then again, someone who's 10 years off therapy starts having balance problems and learning problems. You do an MRI, this is what it looks like. So just put things in context of scenarios that you would maybe write if you were writing a test. All right, and lab evaluations are pretty much what you would do for any kid to look up these problems I just talked about. Just doing a CBC, we do a bone marrow really only in babies or people with abnormal cell counts. Liver function, sometimes we'll uncover liver involvement. It's important to at least ask questions around the ability to handle fluids and sodium because of the risk of diabetes insipidus. I think BRAF V600E circulating cells with the mutation will be something that probably will become clinically important, but I doubt we'll make it to this exam. But if you have circulating cells detected, it's a risk factor for poor outcome and high-risk disease. And then the imaging, there's no really set data on imaging other than PET and CT seems to be the most specific and sensitive in general. And then MRI for imaging of the brain and spinal cord. All right, so therapy, again, there's not a lot of data behind therapy. A lot of it's sort of the art of medicine still, so it makes it hard to ask questions about. But for skin alone, the general concept is you manage with observation or with kind of minimal oral chemotherapy initially to see if you get a response. And really that's only necessary if the lesions are causing some kind of clinical problems. But again, you have to look for other sites of disease, and if it's actually systemic, you really do need to use systemic chemotherapy. We recently had a paper on hydroxyurea as an option. It sort of fits in the same concept of oral methotrexate or oral 6-MP. So low risk and high risk more or less get treated the same. You give vinblastine and prednisone, and after 6 or 12 weeks, if it doesn't work, then or if it's working, you continue. If it doesn't work, then you come off therapy and try something else. And the high risk really refers to high risk of death for people, higher risk for people who don't respond by week 12 of therapy. So radiotherapy and intralesion steroids have been used. There's not a lot of data on that, however. So outcomes. So for low risk, 0% mortality, according to LCH3. I'm not sure that 0% is a hard zero, but I think it's sort of underscored by the event-free survival is 50%. So 50% of kids relapse, and the more relapses you have, the more long-term sequelae you have. So I think it's still a clinical challenge. And then high risk, so it was moved from 20% mortality to about 10% mortality in sort of recent data. And again, we have a really high rate of relapse in these kids. So neurodegeneration, you're at higher risk of neurodegeneration if you have lesions in the front of your face. We don't really know why this happens. We do know that, at least in a retrospective series, people who got systemic therapy seem to have fewer incidences of neurodegeneration than those that didn't. So that sort of suggests to us that it's probably one of the reasons why it's worth treating people with CNS risk lesions and rather than letting the lesions linger. And you have to keep following these patients for a long time. It can be, neurodegeneration can be acute or it can be decades after the initial diagnosis. And then these kids will present with ataxia, dysarthria, dysmetria, behavior changes. MRI looks like what I showed you before. And the causes, textbooks will suggest autoimmune or inflammation. I think there's probably some problems with myeloid cells migrating to the brain and causing some mischief, but those data aren't published yet. All right, and then as far as once you're done with vinblastine and prednisone, half the patients fail. What do you do? So there you're sort of off the reservation. There's no great data about what to use. And so people kind of pull stuff off the shelf, and some favorites are cytarabine, clofarabine. For kids who have high-risk disease who are really in trouble, I think AML-style chemotherapy with 2-CDA and ARC would be the board answer. There are some prospective data around this. And then experimental would be BRAF and MEK inhibitors. Again, a major theme is that there's long-term sequelae in over 50% of the patients with LCH. And it's more common in patients who have longer-standing disease. And then for diabetes insipidus, just be aware that this arises in 15% of all patients, so it's a big problem. And then 50% are going to have anterior pituitary deficiencies. I noticed I said have pituitary, so 100% should have pituitary deficiencies, but 50% will have anterior pituitary deficiencies. All right, pop quiz. We're switching gears again now. So we have a 3-year-old African-American with significant cervical lymphadenopathy for 2 months, doesn't respond to antibiotics, no other symptoms, and there's a biopsy report that says S100 positive, 163 positive, 207 negative, factor 13 negative with myeloproliferative. So what do? So you do nothing. So just observe, because this kid has Rosai-Dorfman disease, which is also known as sinus histiocytosis with massive lymphadenopathy. So another disease with a marketing problem because it's just too much information. And so basically these kids have really impressive lymph nodes, like scary Frankenstein kind of lymph nodes, but they otherwise seem to be fine for the most part. So that's sort of one flavor of Rosai-Dorfman disease. And I think what links all of this is the pathologic finding that I'll show you in a second of myeloproliferative. Myeloproliferative is such a cool word, I guarantee you it'll be on the boards. And so these are basically disorders of macrophage proliferation that we don't quite understand. It doesn't seem to be clonal. In every case, there's starting to be some mutations associated, but we're not really sure what's going on here. I think classic is probably one disease. So here's an example of African-American child with a big lymph node. But then you can extranodal. You see these eye sockets are packed with cells. You can also get it in your bones. I think these are probably very different biological processes that we just don't understand, but they look the same under the microscope. And you can see under the microscope, this is what it is. You've got these tons of macrophages, and when you stain with CD163, you see these lymphocytes just happily trafficking through the macrophages, so they're viable. So that's what differentiates it from hemophagocytosis. And it's just sort of this strange phenomenon we don't really understand. But myeloproliferative, viable lymphocytes trafficking through histiocytes, remember that. Okay, and so for the frequency, most often Rosai-Dorfman disease, by definition, is going to be in lymph nodes because you have these sort of macrophages, lymphadenopathy, sinus lymphadenopathy, right? But then you have all these other sites that can be involved. And I think that's, again, we just don't really quite understand what those diseases are, but we call them Rosai-Dorfman. And it can arise in the setting of sort of reactive hyperplasia. ALPS can be associated with Rosai-Dorfman or can be confused with Rosai-Dorfman. You can have Rosai-Dorfman along with LCH or JXG. It can have it along with other leukemias. It can look like storage disorders. So it's confusing, but just remember myeloproliferative, Rosai-Dorfman disease. Therapeutic approach, it's sort of, there's no data, so but we do know that if you don't do anything, the kids with the lymph nodes often outgrow it, not always. If they have sort of a lesion that's causing problems with their airway or there's other clinical issue, emergent steroids will always shrink the lymph nodes, but they'll always grow back when you stop. There are some reports of cure with clofarabine. But again, for the test, most patients with classic Rosai-Dorfman don't need anything. All right, so one slide on JXG. So JXG is sort of like LCH, but more of a macrophage phenotype. The cells are 163 positive. They're factor 13 positive. They usually have, it's very often skin limited. Again, this is one where dermatologists will often say, well, it's just in the skin, don't worry about it. But then if you dig deeper, a lot of the times we'll find these kids have neurofibromatosis or some other sort of RAS activating condition. So it's, you have to use your clinical judgment, but we think it's worth looking for lesions in other sites in kids who have extensive skin disease. But again, association with NF1 is something to remember. And I think the somatic landscape, the genomic landscape is being worked out, but there are some reported mutations in MAP kinase genes. All right, next pop quiz. NICU consult. So hepatomegaly, splenomegaly, fever, cytopenias, infectious evaluations are negative. Advice for the next step. So everyone's favorite lab, get ferritin. Although I think bone marrow could be okay too, but it's sort of as far as what you get more quickly, I think ferritin. So the point is, think about HLH. All right, so I'm rounding the corner here, and we're going to talk about HLH to wrap things up. And I think this is, again, very, very testable, and it's a disease that's not very well understood, so that's sort of a bad combination. All right, and so what happens with HLH? I told you we were going to stay away from the lymphoid side, but really HLH is a disease of T-cell dysfunction, but it sort of makes the macrophages look really angry, and so that's why the macrophages get blamed with the histocytic name. The important thing to remember about HLH is that it's a syndrome, so there's lots of different things that lead to HLH. For survival, 50% of patients who meet criteria 50% of the patients meeting criteria who are treated will survive. Basically, if patients really have HLH and they're not diagnosed and not treated, they won't survive. The majority of deaths occur in the first 8 weeks, so it's really important to think about HLH and figure out if this is an issue that requires therapy sooner rather than later. And epidemiology is sort of all over the place. I think it depends on your provider, it depends on institutional culture. If Hem-Onc gets the consult first, or rheumatology, whether it's going to be HLH or macrophage activation syndrome, it depends on coding when you're doing research. I think we still really haven't defined what HLH. I don't think we all think the same thing when we say the words HLH. But anyway, with all those caveats, it's about 1 in a million live births, and we estimate that we have about 1 in 3,000 admits to our hospital meet criteria for HLH. So we see about 15 or 20 a year. All right, diagnostic criteria. These are a mess, but it's what we're stuck with because of sort of historical progress. So kids who have fever, splenomegaly, cytopenias, you can have increased triglycerides or decreased fibrinogen, hemophagocytosis, elevated ferritin, and then more recently we've added increased soluble IL-2 receptor alpha, decreased NK cell activity, or you can just have gene mutations that prove that you have HLH. But I think the thing to think about, rather than sort of counting up, oh, you have 4 out of 8 or do you have 7 out of 8, is do these reflect someone who has some kind of pathologic inflammation to the point where that inflammation is causing damage to their organs? So is the inflammation what's causing the renal damage, the liver damage, the respiratory failure? At least that's how I think about it. And then it's named HLH, so hemophagocytosis is often cited, although it's very important to remember that hemophagocytosis is neither necessary nor sufficient for HLH. But this is what it is when people are talking about it. You have these sort of big, angry, vacuolated macrophages that are ingesting everything, and it can be not only red cells but also white cells. Basically, they just sort of stop following rules of personal space and start engulfing everything. Okay, and then HLH-associated genes, this list keeps growing and growing and growing. I think for the purposes of the boards, I would just kind of stick to the ones here. The one that's maybe missing from here that I just kind of realized, but we'll talk about tomorrow in the leukocyte talk, is Shirakawa-Higashi syndrome, or LIST2, has been associated with HLH. But basically the ones in red are genes involved in cytotoxic T cell function and NK cell function. So if your T cells sort of show up to a fight and they, pull out an unloaded gun, it just makes everybody angry, and they call more and more people to the fight, but they're unable to get rid of the antigen-presenting cell. And it's sort of a slightly oversimplified view of the problem. Alternatively, you can have these T cells that are just stimulated and won't go away. So like if they're transformed by EBV, or if you have a T cell defect, that can also lead to persistent antigen stimulation that leads to HLH. And so sort of a cartoon to kind of explain the cytotoxic part of it is you have all those genes I just showed you up on the top of the list are ones that are involved in sort of packaging cytotoxic granules. They kind of pack the bullets. They move these lysosomes to the surface where they poke a hole in the target cell and then shoot the bullet through the target cell to kill it. So perforin is the most common mutation in HLH, and it's the one you'll be asked about on your test. So I just remember perforin if you have to memorize one mutation. All right, and there's all this discussion about, is this familial, is it secondary? And I find that it's not particularly helpful when you have a kid in the ICU who you have to decide to give etoposide tonight because you're not going to get the gene studies back overnight. And not only that, the outcomes aren't really different. So if you look at the HLH-94 data, there's really no difference between outcomes in kids who had suspected or proven familial HLH versus all comers. And so I think that really suggests that people who show up with this phenotype of HLH really require urgent immune suppression, and you can figure out the cause later. And so how does this happen? So basically, as I mentioned, you've got your T cells who are supposed to sort of identify antigen-presenting cells that show the T cell. So this T cell recognizes a specific antigen on this dendritic cell, and it's basically a kill me sign. So it says, hey, I've got this virus or I've got this issue, you need to kill me. But if it shows up and it can't kill that dendritic cell, then what happens is the DCs activate more T cells, and more T cells arrive, and the T cells start producing more interferon, and sort of this cascade of cytokines that leads to sort of non-specific antigen-independent generalized inflammation. And you can really correlate the severity of disease based on the severity of the gene defect. So your baby who shows up in week 1 in the NICU is a perforin null, where your teenager who's maybe had some smoldering kind of episodes of inflammation and finally is sort of tipped over the edge with a really dramatic event is maybe going to be more of a MUNC13 kind of mutation. All right, so secondary HLH. So again, EBV, CMV, parvovirus, et cetera, can be a trigger for inherited HLH, but these are things that are triggers that are really associated with causing HLH. And so I think the herpes virus is basically every virus, fungus, and bacteria has a case report written about it being associated with HLH. One really important thing to think about is malignancy. So, it's not uncommon to get someone who's been treated with sort of steroids for the inflammation for a long time, and then they'll meet criteria for HLH, and you'll give them HLH-94, and then when you take away when you start weaning the topocyte in the dex, their ALCL shows up. I think that happens more frequently than it should. And then T-cell EBV is another problem. So kids from Mexico and from Asia especially are prone to having their T-cells infected by EBV. We don't understand why this happens, but that can lead to an HLH-like trigger. And then we're finding a lot of immune deficiencies are associated with HLH. So as we start sequencing more and more of our HLH kids, we're seeing these sort of hypermorphic RAG1, RAG2 with Gott-Aldrich, a bunch of the stuff that Sun Young Pai is going to talk about tomorrow. And then there's the synthetic HLH that we're now creating. So these kids getting CAR T cells who get encephalitis and get fevers. This is, I don't think the exact same pathology, but it's the same. I think we can frame it in the context of pathologic inflammation from these hyperactive cells that we're giving patients. And there's autoimmune disease that's usually called macrophage activation syndrome if it's HLH in the setting of autoimmune disease. So EBV merits special attention. If you see EBV and something that looks like HLH in your test, there's probably HLH because it's a really classic association. And we think that what happens is that these infected B cells just kind of perpetually irritate the T cells that can kind of lead them to sort of having this exaggerated response. And we're seeing also some associations with the XLP. Kids with XLP, X-Men syndrome, for example, usually very often have EBV as a trigger. And again, EBV and T cells usually more common in Asia, but it can happen in the U.S. And even though that sort of primary EBV infection-associated HLH is considered secondary, there's data to show that early etoposide is associated with improved outcomes. So even here's a case that's secondary HLH, but early therapy is still helpful. All right, macrophage activation syndrome. I don't think anybody really knows what this means. There's actually a Delphi conference that was held a couple years ago where all the sort of rheumatology and hematology experts got together and tried to define what macrophage activation syndrome means to them. And they defined the significance of the factor based on whether the Americans agreed with the Europeans. So if you had a P-score of 0.05, it meant that there was concordance between the Europeans and the Americans. So anyway, that's sort of where we are with macrophage activation syndrome understanding right now. But basically, if you have a kid who's got autoimmune disease and has HLH, that's macrophage activation syndrome. And this is supported by mouse models where if you basically keep tweaking TLR9, they'll develop HLH. And I think one thing to think about is just because you have an autoimmune disease and just because it looks like autoimmune disease doesn't necessarily mean it's not an inherited immune defect. So most of the gene-proven kids at our institution, when we go back and look, they've been to the ER once or twice with Kawasaki's disease. And what's the difference between JIA and HLH when you look at the diagnostic criteria? Again, I think it depends on the lens of the person who sees them first. So I think the bottom line is that HLH is really the spectrum where you have, you can have a perforin null kid who presents with no real insults, but they're going to show up in the ICU with HLH where, if you or I were to get Ebola over here, we'd probably look like we have HLH. And it really sort of is the spectrum of our abilities, of our immune system's ability to maintain homeostasis. So the treatment philosophies, so if you don't think about it, you won't diagnose it. In the acute setting, just observe and trend. You can give supportive care. You can attack the inflammation with steroids or whatever is appropriate to start. In the intermediate term, you want to minimize the antigen trigger. So in addition to giving appropriate levels of immune suppression sort of in the intermediate term, you also want to try to get rid of you can get rid of the EBV, get rid of the cancer, whatever is causing the problem. And the long term is really the key, is like you have to figure out, do you need long-term immune suppression? Can you wean the immune suppression? Do you need to go to transplant or not? And so for lab evaluations, I think cytotoxic T cell function is something that is fair game for your test. So a kid who's got NK cell function defects, you're going to be suspicious for HLH. CD107 mobilization is basically a test to see if you can sort of spit out those lysozymes. So that's not abnormal in perforin deficiency, but it is in other forms of HLH. So CD107 mobilization assay with a normal CD107 with an abnormal NK cell function is highly suspicious for perforin. And then just kind of remembered the genes that I just showed you. Look for virus, bacteria, fungus. Look for malignancy. Look for autoimmune disease. Ferritin's an okay screening test. I mean, over 10,000, you need to scratch your head and look for other things. But there are better cytokines. It just, we have to wait for them to come back from Cincinnati. So soluble IL-2, soluble 163. Interferon gamma itself isn't a great cytokine, but there's some responsive elements like CXCR9, 10, 11 that will probably come into clinical use before too long. And the reason interferon gamma is not great is because even though it's made, it's mostly in the tissues, not much of it's in the peripheral blood. And then you want to see, okay, well, you've got this overt activation, what kind of damage is happening based on it. So that's why you want to look at your CBC for cytopenias, for hemophagocytosis, look at all your end organ function. What kind of damage is this inflammation causing? And then you put it all together to figure out, well, what level of immune suppression does this patient need? And I think the gold standard is still HLH-94. HLH-2004 still hasn't been published, but early cyclosporin doesn't really help outcomes. So I think based on our typical metrics, HLH-94 is what we consider standard. For CNS HLH, that's something that may come up as a question. You can even get isolated CNS HLH. So you have to look in the CSF. If you have pleocytosis, you have to treat that. You can also use MRI to look for inflammation in the brain. If you just need to buy time, you're not sure what's going on, it might be autoimmune, you can use the sort of usual sort of room tools or ICU tools of IVIG, plasmapheresis, or cytokine neutralization. If your topocyte isn't working, alemtuzumab has some data to suggest, or Campath, that it could be used as a salvage therapy. But then if you have inherited defects in cytotoxic function, recurrent HLH, you really need to get stem cell transplant, and the data suggests that reduced intensity conditioning works best for these patients. Interferon gamma neutralization is being explored, but hasn't been published yet. And let's see, well, I finished way faster than I thought, so I have time for questions if people would like to ask. Good luck on your test.